All right, well, good morning. Good morning, and really happy to be here in New York and excited to see this room this way. I recall my first learning session in 2017, and we couldn't fill up half of this room. And it's beautiful to see the interests, the engagement, and just how much this work has evolved. So I'm going to talk about what exactly are we all doing collectively as a group, as a network, how are we improving outcomes? Because that's our theme for today and tomorrow. It's improving outcomes. So that's why we're all here. We're all here with one sole mission, one sole purpose on advancing and improving outcomes for people living with type 1 diabetes. So some of my disclosures and also extending my gratitude to the Amsterdam Charitable Trust and JDRF Fund, as well as our other industry partners. So 4 key things I'll talk about in the next 30 minutes or so. First is the importance of collaboration. You saw that on stage a few minutes ago with our adult colleagues. And you are a witness to that, and you're here for the collaborative spirit as well. So we'll talk about that and what it means for us to collaborate, what it means for us to engage. We'll share some recent data on how exactly our outcomes are improving, how exactly it's the work you're doing every day in clinic, making a difference, not just locally, but nationally and across the entire network. And then what are we doing to actually make sure no one is left behind? What are we doing to ensure that everyone gets to benefit from all these improvements? And finally, in the course of my conversation, I would share what are we learning across all of this? What's new? What are some things that we hope that you take away with you today and tomorrow as well? So 3 main things I think we must be, and 3 kind of key attitudes or 3 things I expect, I'm hoping for, and I'm looking forward to today and tomorrow being about. The first is engagement. And how do we truly engage? And what does engagement mean? And you'll hear that same repeated today and tomorrow. You would see it in the breakout rooms. You'll see it in the industry sessions. You'll see it in the panel discussions. You'll see it in different aspects on that word around engagement. And I feel that's been one of the secret sauce of this collaborative. It's truly bringing together a group of people that are very engaged and willing to do the hard work in building that collaboration, willing to do the hard work in bringing communities together. And I'll share examples on how we as a network have been promoting the spirit of engagement and that leading to the results we're seeing. And then I'll talk about the encouraging aspect of our work. So yes, there's still inequities, and we all know that. But one of the unique aspects, the things and the approach we take in the collaborative is we're moving away from just describing the problem to actually addressing it and seeing those results and seeing the improvement. So I hope that you will leave today and tomorrow feeling encouraged about some of the improvements we're seeing and feeling encouraged about some of the gaps that are closing. And I'll share some examples of that. And I encourage you to also take a look at the different breakout sessions. There are going to be a lot of sessions around health equity, and I hope you leave inspired and encouraged with great practices that you can take to your practice, you can implement tomorrow, next week, next year, and just keep on that, pushing the needle on that. And then finally, we hope to leave you all feeling very excited that finally we are changing the tide. Finally, we're moving the needle. Finally, we're improving population health outcomes, and I'll share some of the results as well. So 2 key papers, if you want to read more about how this network is truly building the spirit of engagement, you can read the commentary, which our co-chair of our publications committee put together, Shivani. And there's a second paper we shared. These 2 papers really describe our work as a group in the spirit of collaboration, the spirit of engagement. This is why we need to do this work. And this is why we started doing this effort in the first place. And if you've been with this network since 2016, 2017, you've seen this slide in different iterations. And I feel that when we started these efforts in 2016, 2017, all of this was becoming very prominent on like outcomes weren't improving, outcomes weren't improving. And in fact, actually, a lot of conferences, 2019, 2020, that's always the first tagline of, a lot of conversations of, well, outcomes are getting worse despite technology advancement, outcomes are getting worse despite standards of care. And a lot of us were very frustrated with that narrative, with that message of outcomes were getting worse. And in the popular paper there in DTT, and it wasn't just getting worse, but when we looked at data from some of our collaborators, and you'll hear more about this later this afternoon from our chair of international collaborations, David Mans, he would share how our work in the T1D Exchange Collaborative compares with other networks across the world. But more importantly, why I'm sharing this slide is if you look at outcomes, you look at pump use, for example, this is looking at data from 2010 to 2018. You look at pump use in T1D Exchange, DPV stands for the German and Austria Registry, MPDA, the England and Wales Registry. So pump use was, better in T1D Exchange Clinic Registry. So this was the prior Clinic Exchange Clinic Registry. So pump use was better there. Like, oh, okay, well, better than DPV in Germany, better than what we're seeing in England and Wales. And then you look at CGMUs as of 2018, for DPV had better CGMUs, but T1D Exchange was in between MPDA, England and Wales, and DPV and German registry. So going by that, we're like, well, we expect that outcomes will be better in the US because we have more robust CGMUs, we have very robust pump use compared to the other two. But that was not what we found in the data with our colleagues at Stanford leading the study. It looked at outcomes and A1C in the last sort of trend line there, T1D Exchange A1C, a much higher 2018, and compared that to what was happening in England, what was happening in Germany, and their outcomes were actually getting better, while our outcomes were getting worse. And David Mans will speak more about this later today, but I think one of the key reasons why I want to share this data is some of the things that we're learning from our international colleagues is the power of engagement, the power of collaboration, the power of sharing. And that is part of why we're changing this narrative so that we move away from just doing the core research, which is good. And we need that, and we need to continue the research. But how do we move all that research, all that insights into clinic? How do we move that to impact the next patient you see tomorrow and on Tuesday and on Thursday? Because just the research alone, and in fact, just access to technology alone will not solve all the problems. We need much more than that. We need to be able to engage in the true spirit of it. And I'll show you a few ways we're engaging in the next few slides. So our journey has evolved from where we were 2016, when the network started. I joined 2017, and it's continued to grow, to where we are now in 2023 with 57 different centers represented. And this map sort of shows you all of the different participating centers. And now we've started to do work in the type 2 space as well. But to truly engage, we're very focused on engaging first with people, engaging with people living with type 1 diabetes. I got committed and I started doing this work because of my own personal connection with type 1 diabetes. So my wife was diagnosed in 2016, and I've had to go through sort of the same journey of being a caregiver, trying to also figure out some of these everyday challenges your patients or any of you that also have a family relation here with type 1, those struggles, and from getting the device to not getting a device, to understanding it, to dealing with insurance, to all of the things you've heard about. So for me, it's more than just the job. For me, it's more than just showing up, or for me, it's more than just papers. I'm having these conversations at dinner time on like, oh, are you using this? Or what's happening with this? Or this is how we should engage with that. But voices of people living with type 1 diabetes, like my wife, are critical to how we move this forward. And I'm so glad that today and online, we have people with lived experiences, or people caring for those with lived experiences here in the room. You would hear from Marissa, and she would share what it means to be a person living with type 1 diabetes and be a self-advocate. You would hear from Jeff, you would hear from Amy, and I encourage you to connect with them as well. I encourage you to engage with them, because that's one of the secret sauce of our group, is that we center the experiences, we center the lives, we center the perspectives of people that are dealing with the struggles of type 1 diabetes daily. And we get their voices in advisory groups, we get their voices in quality improvement, coaching groups, we get their voices in forums like this, on webinars. And we have a lot of people in the room that are more than willing to share their perspectives, to share their interests, to share their struggles, and also give you feedback on what's working and what's not working well. And you know, in this network, we really pride ourselves in that. And I really encourage that as you go through the room, as you have conversations, think about that. Think about how do we center the experience of those living with type 1 to be the core of what we do. You know, with our advisory group at the T1D Exchange Quality Improvement Network, very engaged group. The group actually put together a sick day management guide as one of the products, and a lot of other products that have come out from that group. Now, these are patient voices of people living with type 1, sharing, this is how I manage my sick when I'm sick, or this is how I help my child, you know, being healed. Nicole and Mr. Wolf also did a paper that will be out in endo clinics, also summarizing other ways you can engage with people living with type 1 diabetes. And that's the first piece around that engagement effort. And that's why I'm starting with this on, we truly have to continue to remember and ask ourselves, do we have those voices on the table? Do we have them represented? Are they a part of our quality improvement group? Are they a part of our advisory group in the clinic? Do we have their say on this new protocol or this new strategy or this new workflow? Because we can have best intentions, but if those intentions do not meet the core needs or do not address what people are feeling, we miss out on critical things. So that's where we start, and that's what this group has been about. It's very critically engaging with lives and engaging with people living with type 1. But we move on to engage with ourselves. And we engage with ourselves and we share operational insights. So Joyce was curious on what telemedicine uptake was like at the start of the COVID pandemic. And we did a paper together to look at who was doing telemedicine, what was the change, was it increasing, was it decreasing? And then, you know, a year or two after that, Joyce and Francisco decided, like, you know what, let's take another look at what has happened in the last 18 months of the pandemic. But this is an example of looking at operational issues. And there are a lot of other examples in the collaborative. There are 24 different publications that have come from our group this year alone. And so far, 67 different papers have come from our group since 2020. And the reason why I share those numbers are, these are different papers that really touches on all the different aspects of engagement. So when we have a concern around operational issues, we come together as a group. We try to answer those key questions that we think about. Okay, what are you doing differently in New York? What's happening in California? What's happening in San Diego? How about in Miami? How can I learn what you're doing in telemedicine? Or even what's your workflow like? You know, and Joyce and Francisco led this work to really look at, okay, well, what are some of the things? What was the change in that? You know, and then how do we promote a strong infrastructure for telemedicine? What are some of those things, those factors that can really make a difference? You know, and this is one example, and this paper is up there in clinical diabetes, really sort of demonstrating the power of a network like this to build on the strength of our engagement. But beyond the operational reasons, we also want to engage to capture your clinical insights, your clinical perspectives. And we do that in several ways. So I'll give you another example here. We wanted to really understand what it's like to think about preparing for antibody screening. So yes, antibody screening, and we have some of our industry partners here, and that's another group that we're actively engaging with. So Sanofi is in the room, Mankind, Vertex. But we're engaging with industry partners because we have a shared mission on improving outcomes. So yes, there's potential for us to be able to screen and monitor before people sort of go on to develop type 1 diabetes. What's the insight? How can we learn from our internal group on what are those barriers? How ready are we? What infrastructure are you putting in place? What systems are you putting in place? And you can read more on this paper. But this is an example on those key clinical insights and using the strength of a group like this to really engage and connect with each other to gather those insights. You know, but one of our biggest achievements so far has really been building a robust data infrastructure that we all in this room can engage with. And with that, we've built an AML database, and now with more than 82,000 lives, more than 82,000 people living with type 1 diabetes. And this is something we all can be proud of, because with 2,000 patients here and 1,000 and 500 and 800, we've built a really large cohort that can help us answer very critical questions that might have been hard to answer in the past. So now I'm curious on what's outcomes like for Native Islanders, or what's outcomes like for Native Hawaiians or Pacific Islanders or Asian Americans with type 1 diabetes? Because we're all contributing data and we're all defining that data in the same way, and all putting it into the same space, you can query on that. And a lot of you in this room have used this resource and will continue to use this resource as we grow this. At the peak of this, when we're done with data mapping, there's going to be more than 100,000 people living with type 1 diabetes EMR data that is updated and refreshed every 2 weeks. Now, that's a resource that is robust. That's a resource that is helping us answer critical questions, and we're engaging with that data, and I'll show you a few examples of how we've been doing that. But before I do that, just to really point out that because of the power of our network and our collaboration, we can build this resource that it's also a very diverse cohort. You think about non-Hispanic Black cohort, 13% of the cohort are non-Hispanic Black, or 12% for Hispanic. And then you're going to hear a lot about some of the inequities too we see with insurance. Half of the cohorts are people on public insurance. So now we can also look at outcomes for publicly insured as well. And, and I'll show you some examples of how we're doing that. But more importantly, even look at how about for, people with type 1 diabetes living past 80 years, more than 65, more than 2,000 people represented there. So we have a strong enough group where we can begin to answer more questions than we ever thought we will. And I'll give you a few examples. First, we can start to look at what are changes and variations in how care is delivered, changes and variations in who is getting what. In this paper that Priya, our colleague from Stanford, put together, we looked at CGMUs 2021-2022. So top line is, well, CGMUs increased from 2021 to 2022. So went from about 70% to about 80%. However, when you start to look at the individual sites, and you start to look at CGMUs across the individual site, then you start to see this huge variation from site A to site E to site H. And we begin to ask ourselves critical questions on site A. Why CGMUs this way? And what's happening here? What are you doing differently in site E or in site D or in site H? How can site A learn from site H and learn from site D? But the power of this data is in helping us benchmark, not for competition, but for improvement and for engagement. And that's one thing that we've sort of strived on and built on in the collaborative, to use data, benchmark against ourselves, but benchmark in a way that we can truly learn from each other. And we're learning from each other using our quality improvement portal, and you can read more about it in track 61. There are actually going to be 2 demo stations for the quality improvement portal. So if you're new to the network and you haven't used the portal and you're curious on it, I encourage you to go to track 61 just down the hall, and you get to play around with it. And it's accessible, it's available, and many thanks to all of you that have provided feedback over the years on this. But the improvement portal, it's a real live, active way where we all can get a chance to log in and see our data, the individual clinics data, but also sort of compare yours to another center. So in NYU, you're curious on what's happening in David Mass Clinic, you can go there and like, okay, this is what's happening in Stanford Peds. And Stanford Peds is curious on what's happening in Jenny Sanchez. You want to see what's happening, you want to see what's happening in Miami, you can go there and take a look, right? But that's the beauty, because I go in there, I can look at my data, I can compare it to another site. If they're doing something differently, I can reach out to them right on the portal, right within the same system. I can look at best practices. I can connect with them. I can engage with them, because that is part of the secret sauce. That is part of what makes us unique and part of what makes this collaborative distinct. And a few more examples on how we're connecting and engaging with this data. So this paper led by our colleagues from Nationwide Children, Kajal, we looked at what was happening with insulin pumps and CGMs and how are those associated with outcomes. And Manu was the senior author on this paper. But what we really found, and the main reason why I'm showing you this example is just one example of many that have come out from our group collectively on using this data, answering key questions, confirming a hypothesis, trying to look at, okay, what's happening with trends, what's happening with insights. Okay, well, with CGM use and pump use, and CGM use without pump use, CGM use with pump use, all of those different factors, and you can read more about this, in this work. But it gives an example with all that data, with all that resource, that we can begin to answer more key questions there. And you heard a little bit today from some of our panelists on the difficulties with insurance and how we're even having some people living with type 1 discontinue CGM or discontinue a device because of insurance, because of coverage, because of cost. When that happens, we're able to capture that. In this paper that is in Journal of Diabetes Science and Technology out this year, we followed more than 12,000 people longitudinally, and we're interested in who stopped using the CGM. And when they stopped using the CGM, what happened? And who went on from not using the CGM to using the CGM. And you can longitudinally look at outcomes like this and look at insights like that. And we're using this as part of our advocacy efforts, using this in conversations with different groups we're involved with through our partnership with Hemsley Charitable Trust. We're working with a group called Center for Healthcare Strategies, and they're working with 7 Medicaid offices as well. And that's just one of several initiatives we're part of and connected with, using data like this, sharing insight like this on this is what happens when things get tough and you require us to have to do prioritization every 3 months, every 6 months, people drop. And when they drop, this is what happens with the outcomes. And you can see this for 12,000 lives. And not just my patient, but this is sort of the reality of that, right? So those are opportunities, and those are part of how we're doing the work we're doing and why it's important. Our colleague Elizabeth Mann presented this work at ADA this year at San Diego, and this abstract was recipient of the ADA President's Award. But what she found, she and Priya led this work, what they found was starting CGM early leads to better outcomes, better A1C outcomes in long-term trajectory. I share this as another example of the everyday practical real-life example where we could look at, it's not just on getting on CGM, it's not just getting started immediately on getting on CGM, it's also when do you start CGM? It's do you stop using CGM? What changes in between? So there are tons of other questions we can continue to answer as a group, and this will be this will be converted into a paper hopefully in the next few months. No pressures, Liz, but I know that's on the works there with Prayer, right? But those are a few examples on using the data and using the strength of our data, engaging with the data, engaging with industry partners, engaging with policy advocates, engaging with people living with type 1 diabetes, but we're also engaging even outside of the country. And just to show you one table, and I'm sure you've seen more of this later this afternoon, you look at outcomes, example of CGM, but you can look at outcomes in a ton of other variations and other quality metrics as well. Outcomes, A1C outcomes, DKA outcomes, and what's happening in the US, what's happening in Germany, what's happening in Australia, what's happening in Denmark, where are we doing better, where are we doing worse, what insights can we learn from there? And other papers have been published from my group on this as well. So that's the first broad part of that. That's the strength of this network. It's in engagement. And that's one thing we're hoping that you all would leave today with, that spirit of engagement, and tomorrow in the site tour, in every different aspect of our work together, that we're truly engaging. We're having these conversations in the hallway. We're having these conversations within here, and we're looking for other opportunities to engage. As you're walking through the posters, I encourage you to take a picture of it and reach out to the email address there and engage with the presenters, because that is one of the things that makes us unique. The second broad thing that makes us unique is that we seek out what's encouraging. We look for what's promising. We look for the best practices, and we look for ways to amplify that. And we look for ways to strengthen that. We've done that with some of our work around health equity. So we always are looking for, how do we find those best practices to drive and encourage ourselves to do better? And 2 papers that really summarizes some of our approaches to this, a paper in Journal of Diabetes and also a paper in Diabetes Spectrum. And the reason why this work is so critical is we know the data, and this is a recent paper that is out in DTT. We know that insurance and race are independent contributors to outcomes. Even after you adjust and control for a lot of things, you adjust and control for duration of diabetes, for age, for gender, we're still seeing very strong independent contribution based on race. So non-Hispanic Black, Hispanic patients, when you compare outcomes to non-Hispanic white patients, and by outcomes, I mean being able to achieve glycemic target of A1C less than 7, 34% increase odds for non-Hispanic white group to achieve that as compared to the minority cohorts. And it's even higher for insurance, close to 2 times increased odds for people on private insurance when you match all of the different variables. So those are 2 things that's been very clear we need to pay attention to. We need to pay attention to how we're reducing equities as it relates to insurance, how we're reducing equities as it relates to race. And we've sort of zeroed in on those 2 because we know if we can work specifically on those 2 and close those gaps and reduce those gaps, we'll continue to drive outcomes and improvement. And also in that paper, we looked at sort of what's been happening from 2016 to 2022, and you'd see those lines there, the blue line and the red line for sort of looking longitudinally from 16 to 22 on A1C outcomes for public insurance, private insurance, the public insurance being higher there. And then you look at what's happening for race and ethnicity. So the blue line, the highest line you're seeing there, it's non-Hispanic Black, and then you compare that to the lowest line on the trend chart, which is non-Hispanic white. And those gaps are still there. Those gaps are still persistent. But what's encouraging is that we're figuring out ways to close this gap. With a work led by Ananta, a colleague from Stanford, we looked at what are some of the infrastructure, what are some of the capacity, what are some of the things you need based on all of the things we're learning from you all to be able to start to close those gaps, start to close the gaps in insurance, start to close the gaps in equity. Through the all-site survey we did, we summarized some of those, and this is a paper in endocrine practice from our group that you can read more about. But the big picture message here is starting first with capacity, starting first with understanding, do we have the resources to do what we need to do? If we do, good. If we don't, how do we use this data and use this insights for advocacy and use this insight and use this data to communicate and engage with the administrators, with the policymakers? Because that's where we want to start the work from, and that's where we're starting the work from. But we move on to not just ensuring we have the good capacity, we want to make sure that we know how to do this. And we have a 10-step framework. There are other frameworks that we promote in the network as well on using QI principles to be able to take an initiative, take a quality improvement initiative and go through our 10-step framework, and we try a change. We have a team with people living with type 1 as part of that. We have an equity-focused goal, our smarter goals. And a lot of you have been part of this work already. For all of those, we can bring in that principle, bring in all that insights, and begin to actually make changes on the ground. So in this work from our group, looking at screening for social determinants of health, because we know that if we can address, screen, and refer and close those gaps as it relates to social determinants, that we can begin to move the needle on that. And Dan DeSalvo and group also had a paper showing very close association between social determinants of health and health outcomes. So it's not an abstract subject. It is, the evidence is there, the evidence is clear, right? So, but when you look at that and like, well, we can bring in QI lens to actually significantly improve screening of social determinants of health from not doing any of that to more than 70% uptake. But we can also bring in those same insights, and this work with Ori leading this effort on behalf of our group, working with centers funded by Medtronic, but really from working with centers across all the different CGM devices to look at how do we start to close gaps as it relates to race and ethnicity. So again, that same principle, engaging ourselves, engaging with the community, looking at what's best practices, looking at what's happening, looking at what's encouraging, those insights that we've seen that's working, and then going through all those iterative changes and beginning to start to reduce the gaps in CGM use for non-Hispanic white as compared to non-Hispanic Black, for Hispanic as compared to non-Hispanic white. And this work is still on with 8 different sites here, many of you in the room actively involved in being laser focused on taking all those insights, taking all those strategies to continue to shrink this gap. And all of that effort was seeing the difference here. Look at where we started in 2016, 2017 with inequities and CGM use as a network, as a group. So I'm showing you data now for close to 80,000 lives. And look at where we are now in 2023. And even just visually, and the table is there, you can sort of see, this is for insurance, so public and private insurance. You can see how our collective effort is beginning to shrink some of this gap. There's still ways to go, but we're way much better than where we were in 2016, 2017. And the same, we're seeing the same too as it relates to in 2023 data, our most recent data as of October, and where we compared to 2016, 2017, CGMUs in terms of race ethnicity to where we are now, we're also seeing the same improvement, right? So those are a few examples amongst many of where we're actually closing those gaps as it relates to outcomes, as it relates to use of device, use of technology. And then finally, we're always striving to improve outcomes for everyone. And we are able to achieve that. And I hope that you leave today feeling inspired and excited about the work we've done. And more importantly, the work we have to do ahead. Because we know that if we stay engaged, if we find those best practices, and we encourage ourselves, encourage the team, encourage the administrator, and we work collectively together, and that if we continue to do that, we can begin to improve outcomes for everyone. And two papers really summarize this, the longitudinal trends in outcomes, and then a recent paper that's out in endoclinics looking at improvement in outcomes for people living with type 1. But before I even get to the data on A1C and how that's changing, one of the things we're really proud of is that the culture within our clinics and within our institution is changing. So what you see here is the culture of quality improvement, the capacity for quality improvement, where we were in 2021, 2022, and we have even data further backwards. And why this is important is even if the team structure doesn't change, that's what you see in the upper part, we change the foundation with the QI coaching, with the collaborative calls, we're changing our capacity, IHI Open School, all of the different resources to help you get better in QI. And then all of that efforts leading to successes in what's happening in the clinic. So when we can improve our structure, improve our capacity, improve our foundation, we can take on a lot more things, and we're able to do that as well. But improvement in outcomes are not just at risks of other adverse events. We're taking a look at what's happening as well with decay rates, what's happening with severe hypoglycemia rates, because our goal is not to drive down A1C outcomes, drive on time in range, and then have a lot of severe hypoglycemia. That's far from our goal. We want to still keep track of all this, and we want to ensure that we're also doing initiatives that are targeted towards reducing decay rates, reducing severe hypoglycemia, and we're seeing those as well, and seeing those shifts within the network from where we were in 2016, 2017 to where we are in 2022, 2023. And outcomes are improving for everyone, from the public insured to privately insured, across all age groups. And you look at from 20, from the very young children to 40 years old, 50 years old, and public insured, private insured, everyone is getting a chance to be a part of this because we're being intentional, we're engaging with this, and we're really trying to drive this forward. And then the same way, outcomes are also improving for all race and ethnic groups as well, from non-Hispanic white group, non-Hispanic Black group, and also for Hispanic people living with type 1 diabetes. And that's where we want to be. We want to continue to drive those improvement in outcomes, and you can read more in that paper in DTT as well. But we looked at where we started from, and you looked at the outcomes and the A1C curve longitudinally from where we were 2010, 2012, compared to 2016, 2018, outcomes getting worse. And you look at where we are now, and this most recent data, including 2023 data, and we're seeing a 0.7% improvement overall across a cohort of 82,000 lives. And you think about 0.7%, and for those that are clinical in the room, you understand how significant that is across more than 80,000 people living with type 1 diabetes. So that's where we're going. That's the result. That's why we're excited. But we're excited to even bring this further down. We're excited to do more because we've seen that, yes, there's a way this can be done. There's a way we can begin to shrink those gaps. There's a way we can engage. And doing all of that will lead to us further improving some of these outcomes as well. This year alone, our group has been very productive. caring for more than 100,000 lives of people living with type 1. And with data access for more than 82,000 lives, we've continued to revamp our quality improvement portal, our tool for benchmarking. We have close to 100 different improvement projects happening locally across different centers, and you're going to hear a lot of them. There are 46 different presentations that will happen today and tomorrow during the breakout sessions. So there's a lot of improvement initiatives happening there with the different clinics in type 1 and in type 2 space, showing those improvement in outcomes, 67 different publications in top journals, in JAMA, in Diabetes Care, in Lancet, and Nature. And then we're expanding the work we're doing. So for us, it's beyond just the scholarly distribution as well. For us, it's showing that those outcomes are truly changing, and it is something that we all can truly feel inspired and proud of. So for us to continue to do this work, we need to stay engaged. We need to continue to promote the power of collaboration. We need to look for those best practices. You're going to hear a lot of them today, tomorrow. Let's stay encouraged on where those gaps are reducing. Take those insights and take it to your practice in Seattle. Take it to your practice in Albert Einstein. Take it everywhere and try it out. See if it works in Barbara Davis Center. See if some of the insights that you hear from Texas children will be applicable in Denver. Those are the beauty of what makes this work unique. And finally, let's look for where those outcomes are improving for everyone. And let's continue to promote that, because those are the three key things we've found as a network to truly help us move the needle and truly help us achieve those significant improvement in outcomes. So this is not just about us. This is about improving the lives of everyone living with type 1. And I'm truly honored that we all can be together online and in person to celebrate all we've done and be encouraged for what's going to happen in the future. So a big thank you to all of our supporters, our funders, and we're going to have a picture like this sometime this afternoon as well to capture this moment and capture the work we're doing together. Thank you. I think we have time for 2 questions.
Okay, thank you. So great work. And I think it's so proud that each of us have learned so much from this QI collaborative and has made some changes in the outcomes of people living with type 1 diabetes. But I was just wondering that majority of type 1 diabetes are seen by primary care practices, right? This is just us. How can we bring this learning into the primary care practices? Can we bring them into our QI, which is going to be a little bit tough task, but still, I think that's something to make even a larger improvement in care.
Yeah. Is that a question for me or for Hemsley? I'm just kidding.
Broad questions for both Hemsley and QI Collaborative.
Yeah. No, I think we're very committed to the power and the strength that happens in the primary care groups and the primary care network. So a few ways we're doing that now. We are engaged with ADA. ADA has a very strong primary care group, a primary care network, and we're working with them to take some of these insights and to have that in the primary care setting. There are a few of the centers in our network that have strong affiliations with accountable care organizations. So that's another area we're exploring. It is something that we know we need to do more of. Our change packages, insights from the network are all publicly available, but we know we need to be able to take that into the broad sense. So the short answer is we're doing a few things that we could do more, but we have a roadmap to be able to sort of extend that work in the future. And maybe one more, any pressing question? Or you can always find me outside, I'll be grabbing coffee somewhere. Oh, okay, one more. Yeah.
And it's wow. All right, to piggyback off of talking about primary care, I know that like we are a lot of major centers like in New York, you hear all of us here, but there's so many smaller centers and community hospitals that have diabetes programs that don't get access to all this. And you'll talk to them and they're like, no one can go on a pump for, however many years. And so I do think it'd be something, the collaborative, it'd be great if you had, I don't know, I don't want to say consultants, but someone who could go to them and help with like some of the stuff that we're seeing. And they are serving typically our lower income, population. I just think we have all these resources and even not a lot of resources, but they're not getting the value of our education that we're getting.
No, I think those are good points, and I would love to continue the conversation with this. And I think if folks have ideas too on other ways, and I like that idea on, having liaisons and having sort of like coaches or people that, in different regions, because we're in 22 states now and we cover a wide geographical area. So there's a lot we can do to get into primary care, but I'd love to continue that conversation during the break as well. So we do have time for about 12 minutes of break. I encourage you to engage, and also engage in track 31 and 61, where we have some of our friends as well with us. So thank you all.